Yes, Kerry.
Thank you. Professor, we've got a number of topics to deal with this afternoon, and can I just try and deal with your evidence in relation to the historical controversy, and I suspect we've got a flavour of it already from the evidence that you've already given, but where things are either have gone wrong or have been assumed to be the position, what I really want to understand is what impact that had on IPC guidance and IPC measures. So can I just deal with the first and perhaps one of the main areas of controversy, which is that COVID was not airborne. Now, I gather from all the evidence that you've given that you disagree with that.
Yes.
And indeed believed at the outset that it was airborne, and indeed now in 2024 have firmed up that belief.
Absolutely.
All right. The World Health Organisation's position requires just a moment's examination. In March 2020, is it right that the WHO, World Health Organisation, position on transmission of COVID was that it was not airborne?
Absolutely. They even tweeted about it.
Right. By April 2021, there was partial acceptance by the WHO that COVID was airborne.
Yes.
And it was December 2021 that they stated that COVID-19 could be transmitted via aerosols.
Yes.
All right. Your position is, if I may summarise it, is that by September 2020, and if it helps you, I'm at a paragraph 139 in your report on page 53.
Yep.
And thank you, it's helpfully highlighted there. You consider that by the weight of the evidence presented, and you set that out in your report, and I won't take you through it, indicates that by the end of September 2020, there was enough moderate certainty evidence to strongly suggest that SARS or COVID could be transmitted by the airborne route. Pause there. The reference in there to enough moderate certainty, is that your terminology?
Yes, it is my terminology. I'm kind of trying to look at it in the whole. I was convinced it was airborne, but if we're looking for, there's a range of evidence from a lot of different angles, which we may go into, I don't know. But I felt that it was a good certainty, moderate certainty. It was not beyond absolute doubt, but it was definitely a strong possibility. That's the kind of thing that I'm...
All right, that's what you were trying to convey there.
That's what I'm trying to convey there. I was convinced, and many of my colleagues from my background would be utterly convinced that it was by that time.
Can I summarise it this way? You thought there were a number of sources that pointed by September 2020 to it being airborne?
Yes, yes.
All right. And that was obviously 15 months or so before the WHO in December 2021 stated that it was transmitted via aerosols. Right.
Yes, yes.
Now, we have alluded this morning to the fact that there has been a shift in the scientific consensus from the position in 2020 by those writing the guidance, those advisors and the like, to where we are in 2024. And do I understand it correctly that you consider that shift in consensus was largely driven by scientists?
Yes.
And in your report, if you could just take down the insert, I'm not going to go through it.
Distinguishing between, sorry to interrupt, distinguishing between clinicians and your kind of scientists, or are you saying scientists?
It was driven by people from a multidisciplinary background, predominantly very much influenced by people from physics, people like Lydia Maworska, Kath Noakes, engineers, myself and others for that. But there were clinicians involved in that. There was a letter of, I think, about 230 odd eminent scientists, stroke clinicians to the WHO saying, look, it's airborne. And that, I can't remember the date. I'd have to look at it.
So it was across the board?
Yeah.
Thank you very much.
But they were absolutely influential in that.
Underpinning that evolution from the position at the start of the pandemic to at the end, were obviously a number of scientific papers, and you've set them out in your report, and I'm not going to go through them all, save for one that you consider to be of some import in moving the shift towards people accepting airborne transmission. And can I ask you, please, about paragraph 132 in your report? And if we'd like to put it on the screen, there is a summary of it on page 55. And it's the Skagit Valley super spreading event. And on the screen, it's the entry of the 26th of September 2020.
Yeah.
And just in a nutshell, tell us what happened at the Skagit Valley super spreading event and then why you consider it to be so important.
Right. I just want to set it in context, if it's all right,
Yep.
just very briefly.
Briefly, thank you.
Prior to that, right from March, there was evidence that of people sampling the air in hospitals and finding RNA, so that was around. There was evidence from lab work that the virus could stay viable in the air for long periods of time. This is all evidence leading up to that. People had cultured live virus from the air, and people realised that this was in the aerosols and everything. This led up. So the evidence was building. That's what I'm saying. That's why this is all part of the same picture. And this was the kind of icing on the cake. This was when it's a horrendous event, which some of you may know of, which was a choir had a practice in Skagit, the Skagit Valley chorale, and 61 people were in this practice, and I forget how many hours it was, but it was a number of hours. And I think in a fairly large building as well, a large space. And so they weren't all in close contact with each other. They weren't necessarily socially distanced or anything, as far as I can remember. And 53 of those people became infected. 53 of 61 became infected, and unfortunately 2 people died. And this was reported, first reported, I think, in probably August, but not. The analysis was done with something called the Wells-Riley equation and looking at the whole route of transmission. And the authors came to the absolute conclusion this could not have been by hand contact or droplets. It was far-field aerosol transmission. And that really was epidemiological evidence that confirmed what we had suspected from all the other studies that were coming through.
Fine, and they set out in that little...
So that's why that was a key thing.
I think in addition to the concluding there was overwhelming evidence of long-range or far-field airborne transmission, it perhaps matters not for these purposes, that fomite or ballistic droplet transmission was unlikely to explain a substantial fraction of those 53 cases.
Absolutely.
All right. And you, in your report, said that this study or event gave wider traction to the notion that COVID might be airborne.
Yes, those of us who were working behind the scenes to try and understand this and were convinced it was airborne, this was really helpful because this was further evidence to that. Right. But also people were starting to take notice. Right. And that's when it gained traction further afield because of that. And
to help root this in the pandemic, this is now probably just before the second wave, my lady. And we're around September 2020, going into the second wave later that year. All right. Now, we just briefly touched on the WHO position. Yep. I want to ask you about the position in the UK, and I think you say at paragraph 140 in your report that Professor Noakes, who my lady heard from, I think in module 2, certainly was aware that from the 14th of April, transmission of COVID might be occurring through the airborne route. And she then went on to form the environmental modelling group. And that group, as my lady knows, produced a number of documents in 2020 and into 2021, which showed the change from COVID-19 is not airborne to COVID-19 is airborne. Is that generally speaking correct?
Yes, that's what I'm saying here. I'm using the COVID is not airborne to COVID is airborne as a vehicle to try and convey the change of consensus.
Just before you move on, you said the pronounce it correctly, Skagit Valley, Coral was September 2020, second wave. When I Googled it, I thought it was March 2020.
Ah, right. Shall I
Can you help? Yes.
Yes, I can clarify. Yeah. The first outbreak was reported in emerging infectious diseases, which is the CDC publication, and it reported the outbreak, but didn't do the analysis.
Oh, I see. So it's the
then
analysis that comes later.
the group, it didn't mention Airborne, so a group came together with Professor Noakes, Shelley Miller.
It's right, I don't need to go in more detail.
They did
the event took place in March.
They did the analysis
later.
And did the epidemiological analysis, and this is showing that could not have been, highly unlikely to be by the route.
Thank you for
that takes several months, obviously.
Thank you.
I think I should add that although the environmental modelling group shifted its position from COVID-19 isn't airborne to is, again, I think you set out in your report at paragraph 143, not all scientists agree with that shift. I won't go into that, but it's just to allude to the fact that there isn't always consensus about this.
And it was gradual.
Yeah.
It was in steps.
I suppose really the question comes down to this. Can you help us as to why you think it was assumed at the start of the pandemic that COVID was not airborne? And your paragraph 125 might help you, Professor. It's at page 49 in your report.
125?
Yeah. Essentially, why was it assumed at the beginning that COVID wasn't airborne?
Quite simply, it was assumed it was a droplet-borne was the main route. Droplet-borne don't travel. The large droplets is where it was assumed, in my opinion, wrongly, as it's transpired, that most of the virus was in the large droplets, and these do not travel more than about a metre and a half. Therefore, the only people who can get infected are the people who are in close range. Therefore, it is a droplet-borne. So this, where the virus is in the particles, is hugely important because everything it's kind of house of cards. Everything rests on that.
Was there any basis for that assumption? I mean, why would you not work on the basis that we don't yet know whether there is transmission?
That's an excellent answer. Excellent question. It's an a priori position. So when you look at this is one of the people don't realise, when you're trying to interpret epidemiological data of outbreaks, and indeed animal experiments, you come at it with an a priori position. You say, does it fit with this or what we expect? And the problem there is that when you actually drill down into the evidence, and it's going back to the 40s and things like this, you can't tell whether the near-field transmission is by droplets or aerosols. It could be either, from the epidemiological and the animal study data. But because you take the a priori position, which seemed reasonable at the time, that most of the virus is going to be in the largest droplets, therefore that would explain that these results would be, it's plausible it's in the large droplets. In the fine aerosols, after all, there's hardly any virus at that time, and the PIP report says that in 2011. That's the justification for the whole thing. They actually set that out quite clearly. Because they assume it's in the large ones, therefore all the epidemiological evidence and all the animal studies are interpreted as being droplet-borne. Then people who come along afterwards, they report it. Yes, it's been shown that it's droplet-borne, but it was all on this assumption. If you flip the assumption, if you knew that they were in the smaller particles, you'd say, well, it was all airborne. And suddenly all the evidence would show it was airborne. So it's an a priori assumption that was reasonable at the time, but in the last 10, 12 years, it's been challenged. But whether people are aware of that.
Well, that's what I'm questioning. Is it reasonable if you don't know the route of transmission, surely you should be preparing for and guarding against. I think some corporate participants have called it the precautionary principle, though I'm wary of that because I've heard it has different meanings to different people. But surely you should be guarding against every possible route of transmission until you know.
You're absolutely correct. I another of my hats is doing statistics, and I spend a lot of time looking at that. And one of the problems with stats is generally in medical statistics, we're trying to eliminate what's called a type 1 error, which is we're trying to say something is. We want absolute proof to show that that drug makes a difference. And we're not so worried about when we get it wrong on the other side, the type 2 error, when we say, basically, which is with the pandemic, it's not airborne and it is airborne. We're not too worried about that generally. But in a pandemic, that's exactly what you don't want. You want to be precautionary. So one of the problems was, I think there was a mindset there that followed through. Sorry, I'm waxing on a bit too much there.
Sorry, it was my fault. I interrupted. Sorry,
Not at all, because in fact that's where I was going to get to, because if in reality there is no clear evidence at the beginning of a pandemic about what route of transmission is adopted, do you think it would be wise for recommendations to cover all modes until you know more?
I certainly would do. And this is one of the big complaints that myself and others have, is that people had a kind of confirmation bias, in the sense they confirmed what they thought and they read that into it. And I'm not saying that there isn't droplet transmission, but to rule it out when, just take the simple fact that you always have aerosols with droplets, and that's been known about for many, many years. If you're going to be precautionary, what you see in many of the randomized controlled trials are people are going to a very high bar of proof to jump over, when in fact, as we've seen, there's very little evidence for the handborne route, and yet they don't apply that high bar of proof for that, because that's the a priori received position. It's in the textbooks and that. So that's one of the weaknesses I see of the whole thing.
Thank you. Can I deal with one other or two other matters in this vein? I think you say at your paragraph 150 that there was an important shift in the thinking concerning vocalization, i.e. speaking, shouting, singing. I just want to ask you about that. I think you are of the view that breathing and talking was overlooked as a way of producing aerosols. Is that right?
Yes, and I'd include singing as well,
Yeah.
And shouting. If you think about it, all the emphasis, certainly at the beginning of the pandemic, was on symptomatic situations, so coughing and sneezes. You know, people can see people are infectious, distance yourselves, cover your mouth, wash your hands, all the rest of it. But nobody was talking about just being next to someone who's breathing. You know, think about a patient in bed. And if you think about pre-symptomatic patient, say in that 6-bedded bay, an open bay, the other patient's with them, next to them all day long. If that person's infectious and just talking and breathing, they may not be showing any symptoms, but they could still be spreading the virus. So it's a hugely important issue.
One other allied topic is that of aerosol generating procedures, or AGPs. And can I summarise your position? If I've got it wrong, please let me know. But do you consider that the physical science suggests that many so-called AGPs actually produce fewer aerosols than normal activities such as coughing?
Yes.
That's not to say that some AGPs don't produce a lot of aerosols, but there are some on there that actually produce fewer.
I've got to be a bit careful of not being a clinician. But from the evidence that I have seen, and there's been quite serious studies and meta-analysis done, quite a lot of the AGPs, which were thought to produce a lot of aerosols, don't produce that many aerosols.
AGP again?
Aerosol generating.
Aerosol generating. It's a medical procedure.
Yeah.
So bronchoscopy, for example, would be one where you stick an endoscope down.
I should add, there is not always consensus about what should or shouldn't be on the AGP list. But in general terms, is this the position? There may appear to be an over-concentration on AGPs and the role they play to the detriment of us just talking and breathing.
Yeah. I'll add, if I can add a sentence.
Yes, of course.
Yes, and in my opinion, yes. When you look at the IPC guidelines, the National IPC Manual, there's lots and lots on aerosol generating procedures, and nothing on just aerosols produced, natural aerosols produced through exhalation, including coughing actually, and including that, unless it's classified as an airborne disease, and the only things classified as that are measles and TB are the two, basically.
And just finally on dealing with assumptions, can I ask please that we put up page 45 of Professor Beggs's report? And I hope maybe segue into the pandemic influenza preparedness, the PIP 2011 report. Professor Beggs sets out fully in his report the impact of that, but I just want to look at the two final bullet points to bring it together. You consider that the PIP report was well conducted and correctly identified the significant remaining uncertainty about flu, but it has several problems. Unlike many other studies, it did acknowledge the risk of airborne transmission, but only at close range. Does that mean in the near field?
Yes. Yeah.
And made an important flawed assumption about large droplets conferring most of the infection, whereas you are telling us, in fact, it is the aerosols.
Yes, that's that fundamental assumption. And if I may just take a minute, I like this report. I was really pleased that when I read it, they'd gone into depth. They'd justified why things were there. They'd gone through things, and they were looking at it. But they made the assumption that which was definitely prevalent. The first study that actually found influenza virus in small aerosols, less than 5 microns in size, only occurred in 2010, and they spotted that as well. But they made this assumption that most of the virus was in the large droplets, and therefore very little would be in the aerosols. Therefore, aerosol transmission probably wasn't occurring, certainly not in the long range, possibly, however, it might be occurring in the short range, in the near field. That was their assumption. But they did say that the droplet was the main route. There is another flawed assumption, but I think we're dealing with that in the next. Is it in the next one?
I hope so. Can we look at the final bullet point, please?
If not, I will then.
All right. The reason it's important, my ladies, because the PIP report, many of the findings and assumptions in that then underpinned various guidelines for use during a flu pandemic, and by extension, therefore, other respiratory virus pandemics. And it restricted respirators to only staff conducting AGPs on flu patients. You say there newer evidence that large amounts of virus could be naturally exhaled by infectious patients did not shift this initial policy choice during the COVID-19 pandemic.
Right. Before I do that, I don't want to forget the other point, which isn't here, but it's in the text. The other flaw in the PIP report was that they assumed that once aerosols, as they went out, they fanned out and you got less and less concentration. That's what happens outdoors, but indoors, because they're confined, the concentration over time will build up. And so people in the far field, even though the concentration will become more and they can breathe that in, that was just completely missed in the PIP report. So those two assumptions I felt were flaws in that report. Going back to this here, they had raised, what I did like was they raised the possibility that short-range aerosol transmission was occurring for the first time, which I thought was good. But they were mainly concerned about aerosol generating procedures, as you say, and this is why it influenced future IPC guidance.
Understood.
So it was influential. But there was no epidemiological evidence, as far as I could see, relating to the aerosols in the aerosol generation procedures. I may be wrong, but that I can't remember.
That's your position. All right, and I can take that down, and let me just deal with this. I've obviously asked you a number of questions and given examples relating to hospital bays and nurses attending to patients in that context, non-clinical staff going in and cleaning and the like. Can I ask you, what implications does the significance of aerosol transmission have for IPC in smaller settings, clinics, pharmacies, GPs? Is there any difference if we're looking at a smaller setting?
Right. No, the physics is the same, but it's exactly the same principles. Basically, the aerosols will build up in a space that's poorly ventilated. So in a smaller setting, you might be looking at a doctor's waiting room. You might have quite a tight, confined space with maybe not well ventilated, with a lot of people there. You may also find that the same things apply. The longer you spend in the presence of someone who's infected, and the closer you are to them, you're probably going to get a higher load of aerosols.
So across the healthcare settings, it's important to get right at the outset, or at least not get wrong at the outset, the mode of transmission.
Yeah, physics doesn't change whether you're in a big hospital or a little clinic.
Can I move topic completely to face masks, respirators, and to the extent we need to, visors? Now, Professor, we've already seen an example of an FRSM, and if we want one, there is in your report. And I think perhaps if we could call up page 73, and a very helpful diagram there. But in short, FRSMs protect against droplets, is that right?
Yeah, well, it's a fluid-resistant surgical mask.
Fine.
Surgical mask, right?
But they can't prevent inhalation of aerosols due to their loose-fitting...
Yeah, the loose-fitting masks around the face, they protect the wearer. Well, the first and foremost thing is to actually protect other people by stopping big droplets being exhaled out, so they hit the mask inside and they don't get transmitted to other people. But the aerosols can escape, as you can see in figure 14.
We're going to come on to
we're going to that.
Yeah.
They escape, but they protect the wearer in so much that large droplets heading for the nose or the mouth, but not the eyes, don't hit that. But aerosols can get around the gaps, basically.
And if we look at our figure 14, the first column, A and D, represents the thermal and exhalation plumes produced by someone when no mask is worn and they are sitting quietly. Sorry, A is no mask is worn and D is when the mask is worn. So that's what it looks like if someone is sitting quietly. That's the plume that is produced.
So you can see the thermal plume rising up over them in every case, and you can see, I presume this person's breathing through their nose, and you can see the plume coming down, for the exhalation plume from the nose going down towards the ground, not even going forward. The next one, B, is where they're actually saying also, and the last one is a laugh, actually, yeah. And then the same thing repeated with the surgical mask on it.
My lady, that might be a neat way of encapsulating the role that a surgical mask can play in helping either prevent spread of infection or, in the large droplet case, the inhalation of it. Want to say something? Yeah.
Yeah. Can you see how, when the mask is worn, there is aerosols escaping out around the nose bridge, and you can see how they join into the thermal plume there and then travel wherever, in that sense.
Respirator masks, as we know, are tight-fitting and are therefore designed to protect the wearer from inhaling aerosols.
And they also protect them from pushing them out into the environment as well, but they are designed primarily to protect against all particles, aerosols and droplets.
And my lady's already heard that in the UK we use FFP3 generally, and you have to be fit tested.
They've got head straps that go around the back of the head. That's important because that enables the tight fit to occur.
If a wearer fails a fit test for whatever reason, I think you also say in your report at paragraph 197, but you don't need to call it up, there are respirator hoods that could be used in those circumstances if the fit test fails for whatever reason.
Yes, yeah.
All right. Now, I'd like to ask about the effectiveness of different mask types. And if it helps you, can we go to, I think, around 210 or page 79 in your report? And I think you say, can we take down paragraph 210 for a moment? Thank you. But in short, is it difficult to evaluate the effectiveness of mask types?
No.
Well,
It depends how you want to evaluate them.
Well, let me deal with some of the detail.
A lab
Perhaps
or
it will.
field trial.
All right, let me deal with some of the detail then. I think you said that demonstrating that masks are actually effective at your paragraph 210, inhibiting the transmission of COVID, has proven to be somewhat challenging.
Yeah, right. I think I just need to clarify this because your question.
All right, clarify away.
Yeah, right. So you can get a mask, put it on a mannequin or in a lab, in a control situation, and you can test the effectiveness. So it's not difficult to do that. So that was my answer to your question. Right. If you want to see how they behave in the real world, do they actually stop a pandemic or stop something, you have to do a trial of some nature. And that is tricky because what happens is things change. You get lack of compliance. You get different rates of infection occurring. If you want to do a randomized controlled trial, you can't do a randomized controlled trial because you can't blind it for a start because people know who's wearing the mask. There's a lot of factors. People get vaccinated in the middle of the thing. It gets very difficult to do that type of thing. So it's challenging. That is challenging, the real world thing. The stuff about actually seeing how they behave in the lab, their actual physics of it is relatively straightforward, actually.
It was my fault. It was a bad question. I'm sorry, but thank you for making that clear. There is, however, as you set out in your report at paragraphs 213 and 214 onwards, a findings of a Royal Society review, which conducted, I think, a review of, was it 34 different studies?
Yes, it was, up to Omicron, I think.
Yeah. And I just want to summarise those because they're important.
Yeah.
I think that the Royal Society found that the vast majority of studies they looked at found that masks reduced infection. Is that right?
Yes, they were effective in mitigating and reducing the transmission of infection.
That wearing a mask reduced COVID transmission in the community.
Yes.
And that 7 of the studies found that respirators were more effective than fluid-resistant surgical masks.
Yes.
And that drawing all of the different studies together, the Royal Society found, and perhaps we could highlight paragraph 215, please. There in bold, the Royal Society expert group concluded that the weight of evidence from all of the studies suggests that wearing masks, wearing higher quality masks, bracket respirators, and mask mandates generally reduce the transmission of SARS-CoV-2 COVID infection.
Yeah, I mean, in blunt terms, they found, looking at the whole thing, and remember, stuff that this was done late on after the pandemic, it's much higher quality evidence than early in the pandemic. They found the weight of evidence was that wearing masks was better than not wearing masks, and respirators were better than surgical masks. That's simple as that, really.
Now, they went on to consider the issue of the specific issue of respirators and surgical masks. And can I call up paragraph 218, please, on page 83? And we can see there the Royal Society review stated there was also evidence, mainly from studies in healthcare settings, that higher quality respirator masks were more effective than the surgical type masks.
Yeah, absolutely. They're the N95 is an American classification, but it's equivalent to a FFP2, actually.
Yeah, which is not generally used in the UK.
Not generally used, but good.
Yeah.
Very good mask. Very good mask stroke respirator as well. Yeah.
So translating that to healthcare settings, I think you said a little lower down in your paragraph 218 that there was good grounds for believing that respirators generally perform better than surgical masks at protecting healthcare workers against COVID. And
Yes.
in the similar vein, going on please, in your report to paragraph 221, a number of other studies that you cite in that paragraph, but you say there in bold, are we talking here about a distinction between FFP2 and FFP3 masks? I think we are, so let me let me deal with FFP2.
Let me just have a quick look at this statement and see what it's saying. Yeah.
Right. FFP3 is what is recommended in the UK, although my lady will hear in due course that in the absence of FFP3, because supplies run out, FFP2 was considered to be an acceptable mask in the absence of FFP3.
Yeah.
Right, and so that helps provide some context. Help us, please, with your paragraph 221, though.
Yes. Right. So what I'm saying there is that that first part of that paragraph really should be read in conjunction with paragraph 219. Could I show that, please?
Or just summarise it for us. That's
well, yeah, right. So simply, you can't disentangle masks, face masks, from ventilation. The two are related in the hierarchy of controls, right? And 2019 is building the case here. So here it is here, right? So basically, surgical masks perform better when there's lower levels of pathogens in the air, lower levels of virus in the air. So let me just give you two examples, right? If we had a room with no virus in the air, and we had people wearing surgical masks and people wearing respirators, two groups, you'd find no difference between them because there's no threat, right? You go to the opposite end where you've got loads of virus in the air, you would find that there was a huge difference. The respirators would be really effective because if they're fitting well, but the surgical masks would be ineffective because there's a big super virus out there and they're allowing aerosols to get through. So the effectiveness of surgical masks depends on the viral load, whereas the respirators are kind of immune to that, right? So you've got to look at the load in conjunction with that. So when we come on to 221 now, right? When you're asking me about that, if I can just have it larger, please.
Thank you.
Yeah. That statement where it says this led Chang to conclude that surgicals might provide sufficient protection when exposure levels are low. In virus-rich environments, such as COVID wards, they may not be adequate, right? So in other words, if you've got a situation where you've got a whole load of COVID patients or suspected COVID patients who are maybe even pre-symptomatic or at early stages and highly infectious, gathered together, you've got likely to have a high viral load in the air. Your surgical mask may not be effective against that, whereas if you're dealing with a COVID patient who's maybe just one patient in or a low number, and they're towards the end of their infection and they're not producing as much, the virus in the environment might be less. Therefore, the surgical mask may be more effective in that situation.
So pausing there.
That's what that's about.
So pausing there, in a situation where there is someone dealing with a ward full of either suspected or actually confirmed COVID patients, is that an argument for saying that where there's likely to be such a high viral load, there's a stronger argument for the use of respirators?
Yes, or better quality masks of some nature, but certainly respirators would be a strong argument.
Right.
In fact, that's what the bold bit at the bottom is there, which was Ferris's study, found that healthcare workers wearing a surgical mask had a 31-fold increased risk of acquiring a ward-based infection, SARS-CoV-2 infection, when working on a COVID ward compared to when working on a no-COVID ward. I think I've got that paraphrased right.
All right.
Professor Begg, as a layperson, the conclusion seems to be like common sense.
It is common sense. Sorry, even to a professor of engineering, it is common sense as well.
If you've got loads of it in the room, you need better protection than if you have less of it. Is that what it comes to?
Yeah. But well, it's even in the hierarchy of controls. Yeah, but you'd be amazed that people don't realise that. That's one of the challenges when you're doing a trial. How do you know there's the threats there in the first place? You're comparing two groups who wear masks. One might be in a group. You don't think about this. One might be working on a place where there's a real high COVID risk, and the others aren't. It doesn't make a difference. Do you see what I mean? This is why it's.
So let me draw some of these. No, not at all. Let me see if I can draw some of these threads together, though, because I think you make the point, and others will doubtless make it, my lady, later in the hearing, that the realities of wearing FFP3 can't be ignored here. They are uncomfortable. They can lead to skin irritation. They are hot.
Yeah.
And after, I suspect, this afternoon's break, I'm going to ask you a little bit about FFP2. But let's just pause there, because you mentioned in that answer that we can't ignore the role of ventilation. And I'd like to just come on to look a little bit of that. Clearly, though, when one is talking about masks, it requires compliance by the wearer. And I think you said that you're aware that in hospitals, infected patients were significant drivers of infection amongst healthcare workers and other patients, and that mask wearing amongst patients, and I'm at your paragraph 206.
Sorry, was that 200?
6, which is on page, if it helps you,
Page
78.
Yep.
Mask wearing amongst patients was essential to reduce patient-to-patient or patient-to-healthcare worker transmission, but of course it's difficult to enforce, particularly, for example, if the patient is so unwell they can't tolerate wearing a mask.
Can I just explain that in a bit more in its full entirety, as briefly as possible? So what was found in the various studies have found is that the most of the infection to other patients was from patients who became infected with COVID in hospital, nosocomially infected patients in hospital. And they infected other patients, and they also infected healthcare workers. Right? They drove it. And the reason they did that is because they caught the infection in hospital, and they were there during that incubation period and early infectious periods. That's when they were most infectious. So anyone who came into contact with them was going to be at risk. So they're the kind of key players in terms of driving infection in many situations. So one of the things that my colleague Chris Illingworth and his study at Addenbrooke's was found from his study that was to encourage inpatients to wear masks. Now this is a big problem because these patients are ill. They're uncomfortable, and they're certainly not talking about, we're talking surgical masks, not respirators or anything. And they're trying to get patients to, I think, according to my clinical colleagues at Addenbrooke's, they were trying to do that, but they kind of ended up all over the place, and it was difficult. People have to eat,
Yeah. So if there's a high viral load in the room, one way of preventing you from contracting the infection is mask wearing.
That also helps to keep the viral load down.
I know. But the other way of helping reduce the viral load is therefore ventilation.
Absolutely.
Right. Can we just deal with some terminology in relation to ventilation?
Yep.
Ventilation is the introduction of fresh air to flush away bacteria.
And viruses.
I'm taking your words.
My words, all right.
And viruses.
I obviously was talking about bacteria there.
All right.
Right. Ventilation is this. Yes.
Yes.
It's strictly, it is.
Thank you.
No, ventilation is the action of introducing fresh air, outside air that's clean. To what we do is we dilute the concentration and we flush away the particles in the air. So it flushes away anything that's in the air because they're as aerosols. So that could be dust, that can be inanimate stuff. It could be bacteria, fungal spores,
understood.
and viruses. Right,
Yeah.
so it's indiscriminate. It flushes it away.
I follow that. I was just trying to let's just concentrate on the virus for these purposes. Air conditioning is the movement of air around or between rooms. It's not the same thing as ventilation, is it?
Air movement is the movement of air around between spaces. So in this room, for example, we could have a ceiling fan. We haven't got one. You'd have to imagine it. It would be moving. You'd feel the air currents generated by that, but that's not ventilating the space. It's promoting movement.
Yeah.
And many people get confused between the two.
Yeah. All right. And air cleaning is the process by which the air is cleaned, as the name suggests, with a filtering unit.
Yes, absolutely. So that does move. We've got one over there. And
We're going to come on to
that's,
that.
It's got a fan and air goes through it. So it promotes air movement, but it cleans the air.
All right. Now, can I ask you please to look at paragraph 238 on page 90 of the report. Dealing now with ventilation.
Yep.
Paragraph 238. You say at the top of the paragraph, room ventilation is ineffective against large droplets, i.e. those are greater than 100 microns, because they behave ballistically and drop to the floor.
Right.
Is that correct?
Yes. Sorry, general room ventilation that we normally have. You can have specialist systems that do that, but that's a different animal. But yes, it is correct.
Right. And you go on there to, in that paragraph, make the point that ventilation can only flush away and remove aerosol particles that are suspended in air as these travel with the air currents.
Absolutely. If it's headed for the floor and it's heavier, it's not going to be flushed away.
With respect to this, room ventilation is generally only effective at mitigating the far field infection risk because it can't remove particles in the near field.
Yes, definitely. Again, there are very specialist ventilation systems that can do the near field, but generally speaking, it only affects the far field. It flushes out the particles and reduces the concentration.
And so in IPC terms, room ventilation is a measure designed to mitigate the transmission of disease by the airborne route. Pause, please. Therefore, there is an inherent inconsistency in saying that room ventilation is important while simultaneously arguing that airborne transmission does not occur. This is something that many may fail to appreciate.
Yeah.
Putting that into layman's terms, please.
Yeah, I'm not going to mention anybody. I'm talking in general about things. As what happens is that there's an inherent disconnect between, frankly, you see it all over the place in much of the IPC literature that's been certainly historically, is people generally think ventilation is a good thing, but then they argue that airborne transmission doesn't occur, in which case you'd say, well, if it's all droplet, why on earth we need the air conditioning? Why do we need the ventilation? And, they're contrary positions, and they say, oh, well, it's good to have it. And then, well, if it's good to have ventilation, then you're arguing that there's things in the air and they could be breathed in. So people don't fully connect these, join the dots, if you know what I mean.
I mean, you're never saying you should only have masks or you should only have ventilation. That's not what you're saying.
Certainly I'm not saying that. No, I am saying that I am just saying that there's a disconnect in you need a holistic approach. You need to look at all the routes and you need to have something that's workable.
Now, at your paragraph 240, you set out the ways in which engineers quantify the amount of ventilation required to minimise the risk of airborne transmission. Air changes per hour And you say there it's the number of complete air changes, so the replacements of air that will occur in 1 hour. Just help us with the example that you set out there.
Yeah, right. So we've got a room here. Let's say we had 2 air changes. Doesn't matter what size the room is. Let's say we had 2 air changes per hour. That's the usual ACH is what that means, right? 2 air changes per hour. That would mean that the complete volume of the air in the space was replaced twice in an hour. So if we had a particle of air, I know it's a mixture of air, of gases, but if we had a particle of air, that would mean, or an aerosol suspended in that air, one aerosol, right, one viral particle, on average, it would remain in the room for half an hour at maximum, and it would be flushed away.
So 6 air changes an hour
Would mean that
10 minutes.
10 minutes, yes.
Right.
So that's the kind of longest. You can have, that's assuming complete mixing. You can have pockets of air which are stagnant, and that's why we need to look at how that's moving around in the space. But that means that if you've got 6 air changes per hour, generally the particles are not hanging around for a long period in that space, and therefore, if there's a virus in them, that virus is not having a long time to decay. It's not like a door handle or something where it might be sitting there for days.
Right. All right. Fresh air rate per person you set out there is generally specified in terms of litres of fresh air per person per second. And so, for example, in a classroom containing 30 people, if the fresh air rate of 10 litres per second is specified, you need a ventilation rate of 300 litres per second.
Yes.
All right. Now, we won't descend to the arithmetic in a number of circumstances, but that's generally the way...
Yeah, it's just generally, it's very useful in situations, especially where, like this room here, where we've quite a high occupancy level. If you have a lot of people in one space, one's relating to the room, the other's relating to the people.
Now, I think you make the point in your report that a room can have a region of high and low virus concentration. It's not one or the other.
Absolutely. You showed a picture earlier on, which was from a CFD analysis of a ward, and you saw that all the aerosols were down one side of the ward and not the other. So that's because there was a diffuser like this, actually dividing the air and concentrating it in that area, and it was kind of circulating round. So we were getting air movement, and so it meant that certain people were at more risk than others.
Take another example. There might be a lower concentration by a window that's open than there is at the far end of the room, where you're further away from the window.
Excellent example, because it relates to naturally ventilated spaces. Naturally ventilated spaces are really deep. People don't realise this, but it's a complex fluid mechanics problem. This space is a very, very deep space. We've got some windows. If we were just relying on the windows to produce that, we would have ventilation there, but we could have very still, stagnant regions over here, and it would be difficult. So you can have that, but obviously also where the infector is, you will have likely to have a high concentration. And if you, again, also if you have a strong air current, they might be picked up and deposited somewhere. So understanding how the air moves around wards is quite important, not just specifying the air change rate, in my opinion.
Well, that brings me on to the hospital ventilation guidelines, which start in your report at paragraph 245. And there are what are known as health technical memoranda, which are published. And what do they do in a nutshell, please, Professor?
Yeah, these are basically guidelines for all NHS estates and hospital engineers and people involved in buildings. They deal with the ventilation, so ventilating hospital buildings, basically. But they're actually healthcare facilities, so it could be clinics as well. And they're called specialist ventilation. The most of the concentrated effort is on things like operating theatres, isolation rooms, negative pressure isolation rooms, bronchoscopy suites, things like that. But they also cover general wards and non-clinical areas, toilets and things like that. Although they're de facto the guidelines that people go to. And there's 2 of them. One is for the design of them, and the other one, so they specified the air change rates that should be
Fine, understood, thank you.
and the other one is for the maintenance and operations, so validating how they run, ensuring that they're still doing what they're supposed to be doing.
Now, the HTMs, there is HTMs in England, similar ones in Scotland, and I think similar ones in Northern Ireland and Wales. Is that right?
This is where I'm getting a bit iffy. There's certainly in Scotland and England. There are ones. There's something governing that in Northern Ireland and Wales, what they're called, but they're going to be based on the same kind of standards.
Fine.
Again, engineering and physics is much the same, and that's it. Yeah.
Yeah. Now, the HTMs that were in play during much of the pandemic, is that a document from 2007? And I'm looking, if it helps you, at your paragraph 247 on page 92.
Yes.
The current ones.
Yes, no, I can see that. Right, so, yeah, brief history, right? So, at the beginning of the pandemic, it was the 2007 documents that were valid, and they went through until I think, is it June 2021, yeah?
Yep.
When the new guidelines took over. However, the new guidelines were written before the pandemic.
Right. And whether it's the 2007 or the 2021 guidance, they broadly use the same distinction between airborne and non-airborne.
Absolutely, they use exactly the same. They're just slightly modified in various ways, but they, from what I can see, but the key thing is they use a rigid decision tree. Is the infection likely to be airborne, or is it likely to be non-airborne? Droplet is non-airborne, by the way, right? Or contact-borne. And if it's droplet, then it's just an ordinary ward. You don't have specialist ventilation, you don't have negatively pressurised isolation rooms. If it's airborne, then you need negatively pressurised air isolation rooms and various other things. And the only two diseases that are basically classified as being airborne are TB and measles. TB and measles.
Measles, thank you. I misheard you. Thank you very much.
TB and measles are classified. So this classification of whether it's an airborne or droplet is huge in ramifications all the way through the whole thing.
Now, you say at paragraph 249 in your report that the HTMs, the 2021 ones, classify spaces within hospitals as either being areas where the risk of airborne infection is high and therefore specialist ventilation is required, or areas where the airborne infection risk is low and therefore general building ventilation will suffice. Can you just help us? What do you mean by specialist ventilation?
Right, yeah. So let's get this, the risk is high and low, get that out of the way first of all. If it's deemed airborne, then it goes down a certain pathway, right? So if it's airborne, the risk is high, right, by that. If it's deemed droplet, the risk is deemed low, and it goes down a different pathway. So all the specialist stuff kicks in. So there's really a couple of areas where they consider it really important. I'm talking in broad terms here.
Understand.
Yeah. So the classic one is operating theatres, because there's risk of bacterial infections and surgical site infections. So huge amounts of the documents are given over to operating theatres. That's not really relevant for what we're talking about here in the pandemic. The next area is it airborne? Well, if it's an airborne disease like tuberculosis, then the patient should be put in a negatively pressurised isolation facility with a specialist ventilation system that makes sure that there's a foyer, an airlock that prevents the Mycobacterium tuberculosis from escaping into the rest of the hospital. So it protects other people. And then aerosol generating procedures. The classic, forgive me my loss here, but the classic one's a bronchoscopy suite, where we actually do a procedure with an endoscope to actually take biopsies in the lungs. A lot of coughing, classically done with TB, and classically produces lots of aerosols with potentially TB that are infectious. That needs good ventilation. That's specialist. So you see how the pathway goes down that. If it's droplet, you end up on a normal ward, you know. So,
And I think so on a normal ward, that's not to
and you're told,
denigrate it, but
I think it's 6 air changes is a specified thing for that.
I'm going to come on to that.
Yeah.
But I think you make the point at paragraph 250 in your report that in general, where you're not dealing with those high-risk areas, such as the operating theatres and the like, in general, areas and wards within healthcare systems, odour control is the main reason for ventilation, not infection and prevention.
Yes, so
Infection prevention.
this is the whole point.
Okay.
They basically say, so if you think about in the light of the IPC hierarchy of controls, it just doesn't even figure. This is just saying that the ventilation there's to stop, get rid of smells, basically. No other real purpose, not for infectious purpose, according to this. Obviously, it should be for infectious control purposes.
If there were, for example, an asymptomatic patient on a general and acute ward, the ventilation would be doing nothing to try and help dilute the amount of viral load in that ward.
It would be, no, so the ventilation would be there. If it's 6 air changes, that would be helpful, it's good.
But it's not.
But many wards, older wards, don't even achieve that. But the point is you're not even recognising it, and these are the guidelines. So these guidelines are, in my opinion, out of date.
Right. Can you help me with that? Does the guideline even talk about
it doesn't. It says there's no higher risk on normal wards, and the only purpose in a normal non-clinical spaces and general wards is about controlling odour, making the place comfortable, and you shouldn't be trying to use too much energy. And patients and healthcare workers are at no greater risk. It's written in my report. I've only quoted what they've said. And in the light of the COVID pandemic, I'm afraid I don't believe that's fit for purpose. And I've said that purposely and deliberately, saying that. And I'm saying it now, purposely and deliberately.
Just a few other matters, please, on this. I think you've mentioned already that the HTM guidance says 6 air changes an hour for a general and acute ward, but in your report, you suggest that the evidence shows that actual ward ventilation rates are lower than that.
Yes.
Can you help? Is that dealing with across the UK, or is that based on English studies? Are you able to help with that?
Yeah, I can, yeah. Right. First of all, we've got a lot of very old hospitals.
Yeah.
Right? Hospitals are built at different times. And we have Victorian hospitals, Nightingale wards that are just open the windows, and they're very prone to whichever way the wind blows, basically, in those situations, whether they you get great variation there in the amount of air changes, as I think I say in my article here. But, for example, the ward that I work with closely with Addenbrooke's Hospital. I'm involved in a study there. But when we measured the rates there, they were considerably lower, I think less than 1 air change, for a mechanical ventilation system. Sorry, I need to find it's in here.
You say paragraph 257, if it helps you. The evidence would suggest that
could you put this up? No.
Yeah, actual ward ventilation rates are often well below those specified in the HTM. For example, at Addenbrooke's, as you've just been telling us, Butler found that delivered mechanical ventilation rates to be between 0.96 and 0.73 air changes on 2 medicine for the elderly wards, well below what was deemed acceptable in the 1970s and far below the 6 air changes that we've got now in the 2021 HTMs.
Right. So this encapsulates what I'm saying here, right? So now in the current HTMs, it's 6 air changes as the standard. When the building was built in the 1970s at Addenbrooke's, and that one, it was 2.5. So that was the standard. It was designed to that, which is considerably lower than what we have now. Whether that's a right standard or an acceptable standard is another matter. But even then, when we actually measured the air change rates from the mechanical ventilation system, and what we do is we actually put a hood anemometer over the grills to see how much air is being brought out, we found it was less than 1 air change. So it was not performing to its standard then, and way below the other standard. The bottom one there, the Nightingale ward, basically that's a ward with cross ventilation, lots of windows and no mechanical ventilation. And there's huge variation there because of basically how the wind blows, basically, and whether the windows are open. There are some other. I mean, when I was writing this report, I didn't do.
Can I pause you there?
Yeah.
Because I think we've got the point there that there is great variation depending on the age of the hospital, type of ventilation they've got, and the ability to reach now that the guideline of the 6 air changes an hour. But help me about this. What do the HTMs say, if anything, about non-clinical areas and the ventilation that's required, for example, in a staff room or where the cleaners go to get equipment?
Right.
Do they say anything about it?
No and yes, right? So largely no, right? But if I can just sum it up, right? So I've given the flavour of what it says. Basically, it's saying these are ancillary paces. They're not that important, right? In terms of the ventilation is for odour control and that. You then have a great long list. So there's very little on ward ventilation actually written in the text. What you have is a big table with various spaces listed. So in that table, which covers about 4 pages, you will have things like ancillary spaces. Some will be a sluice, a ward toilet. I can't remember whether there's an office building, a waiting area, how they're gradated, but they'll have usually something, an air change rate, and generally, I don't know, I wouldn't like to comment at this bit, but that's how they treat it, right? It's kind of an also-ran space.
Understood. So there is a concentration, if that be the right phrase, on the high-risk clinical areas.
No, the high risk from according to the criteria of. To me, it's not concentrated on the high-risk areas from a COVID point of view.
Sorry, I didn't mean to cut across you. Do you think that the HTMs in general reflect the risks of transmission from airborne infectious viruses?
I don't think they do at all.
Right.
And from what we know and what we know about transmission of COVID, they don't adequately reflect this. They do put a kind of preamble on them saying we wrote these before the COVID.
I follow that, yeah.
Which they do stress, and yeah, that's reasonable. Yeah.
Just before we break, if I may, my lady, can I just look briefly, please, at the interventions that can be used to supplement ventilation? And, Professor, it's dealt with in your report starting on page 97. Obviously, opening a window, but that is subject to wind direction, strength of the wind, comfort of the patient. If it's winter, that's probably not going to be hugely practical.
Well, I'll just list them.
Do.
They're very useful. Obviously, you could open windows. It's a good way to boost ventilation. But there's lots of downsides. You've mentioned winter. You freeze the patients in winter. That's not a good situation, especially if these are patients who are very ill and need to be comfortable and can't maintain their body temperature. You also get pollutants in from outside. You get particulates from traffic. It's not good for respiratory health at all. Fungal particles are not helpful either. Noise. You get noise traffic. There's a whole load of things. And also, once you've opened them, when you've got a deep plan space, you can't necessarily get good ventilation. It's good in that area, but not further in. So there's limitations, that's what I would say.
Now, assuming that we are dealing with not a new hospital, but one of the older hospitals in the estate, clearly you can't rip down the ceiling and redo the ventilation, or not easily and certainly not cheaply and quickly in a pandemic.
It's hugely expensive to change and upgrade ventilation systems, and disruptive as well.
So the kind of portable or more easily easily built into options include portable air cleaners, is that right?
Yeah, portable, usually they're portable, but we call them supplementary air cleaners. Supplementary devices that help to remove pathogens or nullify pathogens in the air. Pathogens, by the way, can be bacteria or viruses.
Fine. And hopefully there's a figure there giving us an example of what one may look like, but it's easily to put into the ward or the room or whatever you want to.
You have one. You have several in this room, but there's one there.
Thank you very much. All right. There are what are known as upper room UV lamps. What are they, please? You can take that down, thank you.
Right. Upper room UV, it is a technology where you're using ultraviolet light. So we can use ultraviolet light at 254 nanometers. That's UVC light. That actually, when the photons of light hit the virus, they actually destroy the genetic material and prevent it from being able to replicate again and cause infection. So upper room UV, you can put UV in air cleaners like that in a box. So they're doing the same as the filter, the HEPA filter, the high efficiency filter, although the technology is different. Or you can actually put them on fittings up under the ceiling at high level above people's heads. You can't see the actual field, and create a UV field. Now, this is a very old technology that was used in the 1930s and 40s, right up to the 60s in the States, on TB wards. And what you're doing is allowing the natural air convection currents to take the pathogens, in the case of TB, through the field, and it's getting zapped. It's above the heads of people, so it's safe, but you can get a huge equivalent air change rate.
So pausing there,
So
there are a number of ways of trying to improve the ventilation in a ward, in a staff room if we wanted to, in any number of settings. And I think you say that these portable interventions have a role to play in a pandemic, because there's a balance that needs to be struck between ventilation in non-pandemic times and the ventilation that may be required during a pandemic.
Yeah, I think this is, well, first of all, I'm not the only one saying this. Sage EMG said this as well, right? But to be honest, I actually was, throughout the pandemic, I had a central role in trying to promote this. I could see that no one was doing this, so I actually got these trials off the ground to Anne Brooks and to do that. So I was very much an instigator in trying to promote the use of this and get the trials to get the evidence. Because I could see that we hadn't got the evidence. Yeah. Going back to what you said, they've got huge potential. You've got an estate, money short. In everything, we should be looking at utility. What can we do? The biggest bang for our buck. So we've got wards that we can't necessarily upgrade the ventilation system. And actually, do we need the ventilation? You know, in a pandemic situation, if you've got a ward that's used for cohorting patients, you might need a very high ventilation rate. But when it's not being used for that, you don't need as much. You're not going to change the whole ventilation system for that. It costs a fortune. But you can bring in portable air cleaners and, in theory, achieve the same effect relatively cheaply. They're very flexible. And these are things that should be looked at, in my opinion.
All right.
That's what I'm trying to say.
I think you made reference there to SAGE, and they published a report in November 2020 where effectively they endorsed the use of portable air cleaners to provide supplementary ventilation in spaces that were poorly ventilated.
Absolutely, yes.
Now, can I just ask you...
That was a very useful document as well. There was nothing out there before that.
Yeah, because is this the position that there were no guidelines to help hospitals as to what type of portable ventilation they should or might think about installing?
Yeah. Well, I was looking at this back in 1999. When I first started looking at this, there was no guidelines. That was upper room UV. There's been no guidelines at all until the pandemic. So we knew these technologies could potentially be effective, but nobody knew how many filters should we put in a space, where we should put them to best effect. We still don't know. It's very difficult. It's a complex fluids mechanics problem.
So is there effectively a sort of ad hoc way that a hospital might decide to do it, and it might be done in one way in one hospital and another way in another?
Yeah, this is what happened. I can only speak from my experience of what I observed in various places, but people put, they were put in wards, but they were sometimes put, not by us in our trial, but sometimes put in corridors, probably having a minimal impact. If you put too small a unit in, it's not going to have the effect. So
now pause there, because it's right to note that since the emergency stage of the pandemic finished in May 2023, NHS England produced 2 technical bulletins which effectively provided some practical guidance regarding the use of filters and UV air cleaning devices. Is that correct?
Yes, they were built on the SAGE initial document. They were very welcome, in my opinion, because they again brought it to the forefront and the potential for it. But the trouble is that I'm just going to use a term here, the applied research is not there. The fundamental research is there. We know that these things kill the virus and clean the air. How to use them and where we should use them to best effect is not. And so the guidelines can only reflect the research. This research should have been done for the last 20, 30 years, and because it's not there, we need to do it.
Final question for me on this topic, please. I just want to go back to UV lamps. You mentioned that they obviously may pose a degree of risk to health.
I would say that the risk of the upper room UV is 254 is fairly well known. It's fairly minimal. The biggest danger there is if someone does something stupid like climbs on a desk and looks up into the UV. They're blinded, so they've got baffles to stop people looking inside. So you're shielded, you can't see them. That's an obvious thing. Also, if there's a reflective surface that they reflect onto someone, they can irritate the eyes, basically. The other one, 222 nanometers.
Well, I don't probably need to descend to that, but given that there is a degree of risk from a UV lamp, do you think there are more advantages to HEPA filters, the portable units, than there are over the UV lamps if we are looking at proposing one type of portable ventilation over the other?
I think that the HEPA-filtered portable filter units are an existing old mature technology that's well understood and therefore is ready to go quickly, and we should see if we can get as much utilisation out of that. But I also think the potential bang for your buck of, say, upper room UV is well worth looking at. We need some trials to look at that because that might be useful as well.
I'm going to move on to a different and final topic with the Professor.
Certainly, I shall return at, well, let's say 15 minutes.
Thank you, my lady.
You can all work out what time that is. Ms. Carey.
Thank you, my lady. Professor, in your report at part 5, which starts on page 104, you set out key findings, which are effectively a summary of all of the detail that you've included in the preceding pages. But can I see if I can summarise it further, if I may? And please correct me if I'm wrong. But I think your key findings can be summarised as follows: that COVID is transmitted also via the airborne route.
Yes.
So we've got droplet and airborne, and you would say to a lesser extent contact and fomite transmission.
Yes.
And if you were to be asked whether you think there is more aerosol transmission than droplet transmission, would you be able to opine on that?
I would most definitely say that I believe that there is more aerosol transmission, airborne transmission than droplet. The precise figures I couldn't tell you at this moment.
I understand. All right. You consider that the majority of the exhaled viral load is in aerosols, either smaller particles.
Yes, I do.
And it's the aerosols that penetrate deep into the lung.
They penetrate up the nose to the receptors and the upper respiratory tract, and the smaller aerosols penetrate deep into the lung. But they penetrate into the respiratory system.
From your perspective, the 5-micron distinction that we looked at earlier does not accord with the physics?
Yes, definitely.
And the 100 micron diameter should be the dividing line between droplet and aerosols?
In my opinion, that should be the case. Obviously, it's a little bit of a movable feast depending on things, but basically that's it's the ballistic to the aerosol.
Well, that's what I was going to say, and the reason for that dividing line in your evidence is because particles less than 100 microns can travel longer distances, float in the air, whereas over 100 microns, they behave ballistically.
Yeah, and to add to that, the ones that float in the air can be inhaled.
Yeah, quite.
Yeah,
Thank you.
whereas the others, it's very difficult to be inhaled, right?
Right. You consider that to concentrate on aerosol generating procedures is to lose sight of the fact that not only do some AGPs produce fewer aerosols than coughing, but we lose sight of the fact that breathing, talking, shouting, singing are ways of producing infectious aerosol particles.
Yes. However, I would like to just add that in saying that I believe that there's too much emphasis in those guidelines on the aerosol generating procedures as opposed to the natural aerosol generated by exhalation, I'm not saying that the aerosol generating procedures are not important.
I follow that.
Yeah.
Yeah. It wasn't to diminish them, but it's to lose sight of all the other ways in which one can become infected.
Just concentrate on their own is incorrect in my opinion.
I think you said to us earlier that good hand hygiene was important, but the evidence that it substantially mitigates transmission of respiratory viruses is relatively weak.
Yes, it is relatively weak, looking at the Cochrane reviews and other reviews. Nevertheless, good hand hygiene is good because there's other pathogens, bacterial pathogens, MRSA, things like that. So, I'm not against good hand hygiene. It's very important. And it's easy, that's the point. It's easy utility, you can do it.
Yeah, quite. In relation to asymptomatic transmission, which for these purposes include the pre-symptomatic stage, you consider that by September 2020 it was clear that there was widespread asymptomatic transmission.
Yes, I would say there was a strong body of evidence to strongly suspect that was going. Well, no, yeah, it was. And as a precautionary thing, we should have been concerned about it, yeah. From my understanding.
Yes, to final summary by me, whilst the fluid-resistant surgical masks are helpful at reducing exhalation of droplets, they offer limited protection against the inhalation of aerosols.
Yes.
Full protection is provided by FFP3 masks, but there are practical considerations such as the need to fit test, how comfortable they are, that may limit the utility of the FFP3.
Absolutely. They when fitted properly, they prevent aerosol inhalation and infection by that route, but they're uncomfortable, they can irritate the skin. There's a whole load of baggage that comes with them, so the utility is not so good.
And finally, as we just discussed before the break, COVID-19 highlighted the need for good ventilation in healthcare settings and indeed in other settings.
Absolutely. Absolutely.
Can we turn then, please, to your recommendations? And, Professor, they are at 112 in your report. And perhaps if we put those up on screen as well, it will help those following. Now, some of these we may have touched upon already in your evidence, but your first recommendation is there needs to be a more multidisciplinary approach taken to future pandemic preparedness by the government, including but not limited to hospital IPC. It include scientific advice from experts similar to the SAGE Environmental Modelling Group, but also working on pandemic preparedness as well as the emergency response. In a nutshell, why do you say that there needs to be a multidisciplinary approach, and who should be part of it?
Well, having looked at an awful lot of evidence and read an awful lot of papers and looked at an awful lot of reports, what becomes absolutely clear to me is that some of the fundamental errors, in my opinion, or assumptions, could have been maybe avoided, or things could have been flagged up if people had had the expertise from certainly from the engineering physics background and understood more about how aerosols behaved. often people are coming from reading what other epidemiological studies have done. Their training is in medicine or in microbiology or nursing, and they maybe miss things that I would spot. So I'm not saying it's me or, but we need someone. There's very few people with, I straddle both biology and that. That's not a common environment. But we need to have people, and there's a whole raft of people coming through from the pandemic who've learned from the engineering who've gone into this area to look at because of the pandemic. So they're out there who have that kind of physical, biological science side that could give extra expertise, and I think that would be very useful. I've also added it should be in preparedness rather than in response. So one of the good things that's come out of the pandemic is a whole lot of engineering schools have suddenly woken up to the fact that there is all the stuff I've talked about is actually engineering, and there's a whole lot of PhD students and other people looking at this area. So the expertise in this area has grown.
So you're drawing a distinction between preparedness and response, because Catherine Noakes was part of SAGE, wasn't she? She chaired the. She was the modelling subgroup.
Right. This is where I'm at a slight disadvantage, not being an insider in that. I know Kath very well, but she was. I understood that the environmental modelling group was something set up for the pandemic. Wasn't standing. Is it now standing? No,
it was set up. Well, I think it was set up for the pandemic. Certainly, it was SAGE's for emergencies.
Yes, but the EMG was a subgroup of SAGE.
Yeah.
It was, I think it was. Yes. Well, SAGE goes on, doesn't it, in various ways? It's not just for the emergencies, or have I got that wrong? No.
Well, we're going down a.
Sorry, I'm showing my lack of. This is.
It's just that you're saying make sure that the likes of you or Catherine Noakes or people with similar expertise are involved in planning, not just response.
Yeah, make sure. Yes, when you're preparing for the next pandemic, get people from all disciplines to get a good idea of what's going on. So Catherine Oakes joined SAGE, but not at the beginning, after, I think later on, actually, as well.
Right, we can check her evidence. I've already heard from her, so we can check.
Okay.
Yeah.
Right, Ms. Carey.
Can I ask you, please, you've always alluded to the fact that at present it's not able to say the amount of transmission is airborne, the amount of transmission is droplets. I don't want to go over that again, but recommendation 3. Much confusion currently exists in the terminology used in the healthcare system guidance from the UK. And that's before you even add the WHO guidance into that. What do you say and how do you say we can resolve differences in terminology?
Right, well, first of all, to say the WHO is actually looking into this whole area and is making slow progress from what I can understand. On this whole issue. And I think one of the things that we could do is actually some education so that people who are from a clinical background would actually have explaining what an aerosol is and how things work. Then they would have a better understanding, and then that would start to bring people together. The problem is that people are often talking about the same thing, but using totally different terminology and being totally confused. And with a bit of education, the problem is that some people are a little reluctant to change their opinions. I think that's fair to say. But,
how do you think the UK should go about changing the terminology?
Well, I think they've got to do it in step with the rest of the world. I don't think you can do that. But I think this education thing, once people start to understand how these things behave, then they realise the need to change that terminology. And that would help people to come to agreement, I would have thought. It's when people just looking at their guidelines from their discipline and don't understand maybe the fundamental physics going on underneath.
You have referred in your evidence already to the fact that you consider there is a need to revise and upgrade the HTM guidelines on hospital ventilation. So I don't need to ask you about that.
I do believe
that's a firm
the case.
recommendation you
Yeah.
make. And in relation to portable ventilation, as we were just discussing in the break, do you consider there is need for more evidence and indeed guidelines on the deployment of portable supplementary air devices?
These are, certainly portable air filters, HEPA filters, are low-hanging fruit. They're cheap, easy. We know they clean the air. We know they do a similar job to ventilation. If ventilation's good, then portable air cleaners are good. What we don't know is how many do we put in, where should we put them to best effect? So it's applied research, which in the big picture of things is fairly cheap and it's quick to do. But we need to know where we should be putting them to get best effect. And that should be reflected in the HDM guidelines as well, because they should be just as a standard procedure, I would say.
You consider there needs to be, at your recommendation 6, a need for further multidisciplinary research to better understand how air and indeed infectious aerosols move around hospital wards.
That goes back to the slide that you showed, which showed the aerosols, the particles all on one side of the ward. In other words, we assume when we talk about air changes, when we specify air changes, we assume that it's all completely mixed and it does the job. But when we do CFD, we suddenly realise, there's pressure gradients, things are, that diffuser is actually putting the risk up for these people in this side of the room. The aerosols are going out into the corridor. We need to understand how to do that better. Again, it's applied research.
Right. Now, that recommendation there, you concentrate on hospital wards, but just thinking about all those non-clinical areas.
Oh, non-clinical as well.
Would you include those in there? That generally, we need to understand how the air moves around the hospital.
Yes.
Yeah.
Yeah. In fact, non-clinical hospital waiting rooms are really important. Waiting areas are really important areas.
The final one I would like to concentrate on before I conclude is masks. All right. Now, we have, through you, examined the efficacy and otherwise of FRSM versus FFP3. And you've mentioned a number of times that there are potential practical problems with widespread use of FFP3. It needs to be fit-checked. It's uncomfortable. It leaves, does it not, staff, patients, whoever wants to wear them with a slightly binary choice.
You're absolutely right. This was the one thing that, my brief was to look at the science of these things, and as I looked at it, obviously I knew about the science of both masks, but when I looked into how they were being used under the guidelines, I realised that all we had was essentially, in the NHS, a binary choice. You go down one route, that's respirators, if that's kind of specified, in which case then it falls under the cost regulations and HSE. Otherwise, it's surgical masks. And from a point of view of preventing airborne infection, from the science point of view, one is it's all or nothing. These, if they're fitted properly, the FFP3 masks prevent airborne transmission. The surgical masks, there may be a little bit of inhibition, but they're not that effective. So they allow the aerosols to get through. And as a scientist, that made me think, well, there's an awful lot in between there. Surely we can improve and get something with, I want to say utility, if you don't mind. These have got the surgical masks, good utility, but not effective against airborne. FFP3, very effective, but not good utility. They're difficult. They come with baggage, if they're right.
Now,
in the ground, there must be maybe an optimum solution that we could achieve.
Let's look then, please, at what you say on your page 113 at recommendation 5, which is a good introduction to this recommendation. There you've made the point already, FFP3 provides better protection for healthcare workers caring for patients with COVID than surgical masks. It raises the questions as to whether the FRSMs provide adequate protection to healthcare workers when caring for COVID patients, or indeed for those who are asymptomatic.
Yeah.
Therefore, barriers in the way of wider respirator use, whether due to guidance, regulation, fit testing, supply or comfort, should be addressed urgently by the UK government to ensure that more effective respiratory PPE is widely available before and during the next pandemic. That healthcare workers are better protected. In particular, consideration should be given to alternative face mask solutions, such as FFP2 masks with ear loops, which offer superior protection against the inhalation of infectious aerosols compared with surgical masks, while being more comfortable than FFP3 with the head straps. And of course, you don't need a fit test.
Shall I?
Now, let's break that down. I have an FFP2 to show an example of a type of FFP2, which is potentially a middle ground between the FRSM and the respirator. Why do you think there should be more consideration given to that middle ground?
Right, so this really comes from public health and also from the point of view of reducing nosocomial infections. First of all, I don't want to be prescriptive. It's just that when I looked into this, there was the FFP2 mask with ear loops, which was already there. So it was a kind of low-hanging fruit that might be applicable if used in the right way. So what we have at the moment is we have a binary situation. And when you go to the FFP respirators with behind-the-head straps, they're uncomfortable, they need fit tests, you get hot. There's a whole load of baggage that comes with it, which makes them difficult when you're in a working environment. And they fall under the COSH regulations, so they need to be fit tested, and there's a whole load of stuff there. These don't stop the aerosols, but in the ground in between, from the point of view, I'm interested in the greatest benefit for the greatest number. Right, so the greatest benefit for the greatest, that's very much like a public health point of view. You're trying to use interventions that mitigate the transmission. They don't do it perfectly, but they reduce it. And when I was looking into this, I was finding studies where people had looked at FFP2 masks with ear loops, especially in Germany, and they were finding that there was a performance that was 50% better than the surgical masks. They were performing much better than the surgical. And these were straight out of the box without adjustment of the nose loop. And when you adjusted the nose loop, you got much better performance. They're not fit tested. No. So these would fail as respirators, and we're not trying to pretend that they're behaving as respirators. They're behaving as masks. But potentially, that might be a middle ground that's got better utility, causes less discomfort to healthcare workers, provides better protection against aerosols, and is reasonably cheap and is easier to use. And I'm not wanting to be prescriptive, but what I'm saying is this is an area which we should be investigating, or the health service should be investigating.
So is your recommendation, in short, that the government needs to investigate that middle ground and whether there is a form of protection, whether it's FFP2 or not, that can provide that balance between the higher levels of protection with the added uncomfort and all of the baggage, as you say, that goes with FFP3 and the lower levels of protection?
Absolutely. I'm looking, there will be an optimum sweet spot, and that might not be the same for every environment. And remember, it's got to be taken into account with the viral load in the air.
By no point, Scary, thank you.
Thank you. All right. It's finally this, because there are some questions from the core participants.
Right, sorry.
Would you support a recommendation that there needs to be better education about airborne transmission for healthcare workers and those completing risk assessments?
Definitely.
My lady, that does conclude my
Just before
questions.
I turn to questions from the core participants, clinically vulnerable families wanted to ask you questions. I'll turn them down, but I'll ask in summary because I think they probably go without saying. If you improve ventilation in hospitals and obviously protect in so doing clinical and non-clinical staff, it goes without saying, does it not, that it also help protect patients?
It does, yes.
It also goes without saying that the most vulnerable patients will be the better protected.
Yes.
Thank you. And this is a question that I was thinking about too. In relation to portable air cleaners, in normal times, i.e. non-pandemic, do hospitals have these portable air, or are they only brought out in emergency?
As far as I know, they weren't being used, but they appeared during the pandemic. They've been known about for years.
But the question is, I mean, do all hospitals have a supply of them? Should we be using them all the time?
I take that back. I used to be Professor of Medical Engineering at Bradford University, and I certainly was aware that there were units being sold. They were probably being used in operating theatres to provide extra ventilation. So they were being used in certain specialist places. It's an old and well-known technology, and they're easily obtainable, you know. Has that answered the question? Sorry.
Well, I think the answer is that the more of them about, even in normal times, the better ventilation you have, the better the chances of patient and healthcare worker safety.
Yes.
Thank you. Right, now...
My lady, can I just correct one thing? Professor Beggs was kind enough to indicate that there are some revisions to paragraph 18.
I've got them.
Your ladyship will have them, but they've not been read into the record, and I'm asked to do so. It's 2 minor revisions, but essentially the sentence should read, but now in August 2024, it acknowledges that the inhalation of infectious airborne particles, i.e. aerosols, is likely an important route by which SARS-CoV-2 and other respiratory virus infections can be transmitted. And in the final sentence, where it currently reads droplet/aerosol, it should read droplet/airborne.
Thank you.
Thank you, my lady.
Excuse me, there's one thing you missed there. Sorry, I'm looking at it. It should be Appendix 11A, which I think it says.
That's fine. We'll deal with that. Thank you very much, my lady.
Well,
Thank you. I'm now going to allow some of the call participants to ask you some questions. Professor, they have limited time, so I often have to say this to witnesses. Please remember when giving your answers that the longer your answers, the more you eat into the time that I've not so generously allowed them. Right, Miss Fubister, where are you? There you are.
Thank you, my lady. Professor Beggs, good afternoon. I represent John's campaign, Care Rights UK and Patients Association. A lot of our questions have actually already been covered, so I anticipate we'll be a little bit shorter, you'll be pleased to know. So starting with this one, you explain in your report, and you've mentioned today, certain differences in opinions among scientists, whether between clinicians and physicists or otherwise. When scientists are offering information to government or advising government, do you think that those making decisions should be given an overview of differing opinions?
Yes. I think the one thing it's not cut and dry. You know, there are quite a few clinicians who also share my viewpoints. They're not from an engineering or physics background. I think that people need to be aware of the physics underneath it. So you use the word opinion. They need to be, a lot of this is known, it's fact, it's well understood about behaviour. They need to be aware of these things, underlying things, then that will influence their opinion on the epidemiological evidence. Does that make sense?
Yes, it does, thank you.
Yeah, so I think they definitely need to be aware of the science. So if, for example, I'm not trying to give any real situation, but if you have someone who's from a public health background and they're talking about airborne transmission, they will talk about what they've learnt and what they know from the textbooks and the epidemiological trials, but they won't necessarily talk about thermal plumes or any of the stuff that I've been talking about here. And so it's very helpful to have that knowledge as well so that you can interpret the epidemiological data.
And that feeds into your recommendation about having a multidisciplinary
Yes, that's why, hence why I've said it.
Thank you. On to another question. If I could ask you to look at page 65 of your report, at paragraph 165. It's right at the bottom of the page. If you can pull that up, if you just have it in front of you. Yes,
Where is it? 65?
it's now on the screen, I think.
Yeah, and what is it? 165?
Paragraph 165. So the paragraph starts and here you say that there were studies that showed that most of the virus was in smaller respiratory particles. And the second sentence from the bottom, so you did touch on this briefly already, but this is just to pick out a particular point. You say that the authors of the PIP report were aware of Lindsley et al.'s findings and commented on them in their report. However, their conclusions downplayed those findings in favour of the assumption that most of the viral load is in the larger droplets. And so I have two questions.
Yep.
The first is that based on the knowledge available at the time, should the authors of the PIP report have given more credit to the Lindsley report? Or taken it on board more rather than downplayed it?
They looked at they were reporting the consensus at the time was that the virus was in the larger droplets rather than the small aerosols. Lindsley had just come out, and I think they should have taken more notice of that because this was actually hard evidence. This was actually experimental evidence which undermined an assumption. The assumption, I don't think there's any evidence out there for the virus being evenly distributed throughout all the respiratory particles in the large droplets. I'm not aware of it. It's always been an assumption that's been repeated from way back. And here was some hard evidence coming out saying, no, it's in the small aerosols. Well, you've got an experimental evidence against an assumption. Therefore, in my opinion, I probably should have given more weight to that. But I'm not going to be too harsh on that. It just come out. There's, there was a lot of other evidence and that they were
Understood.
going with,
And if
perhaps they were being cautious. That's what I would say.
If that report hadn't been downplayed so much, do you think that might have made a difference to the thinking about the transmission of COVID-19? Undoubtedly, because that would have immediately undermined the assumption of the droplets, as far as I'm concerned. And there's numerous studies now. They're on the public domain, and you can see that the viral material, the RNA, and live viruses. The bulk of it, over 80%, is in the small aerosols in some of these studies, implying that they're coming from different places in the lungs. That would have had a profound difference to that preparedness. Thank you. Those are all my questions. Thank you, Madam.
Thank you very much, Ms. Hubert. I'm very grateful. Mr. Thomas.
Thank you, Lady. Professor Beggs, you'll be pleased.
Are you switched on, Mr. Thomas?
Sorry. Different position. Professor Beggs, you'll be pleased to know that one of the questions I had has been you've already answered, and forgive me for the positioning. I'm representing and asking questions on behalf of FEMHO, the Federation of Ethnic Minority Healthcare Organisations. And just to give you a little bit of context, FEMHO is deeply concerned about the challenges surrounding infection prevention and control, particularly the disproportionate impact it had on Black, Asian and minority ethnic healthcare workers and patients. So with that context in mind, let me ask you the one and only question that remains, and it's this. In your report at paragraph 229, you reference the SAGE report, Masks for Healthcare Workers to Mitigate Airborne Transmissions of the SARS-CoV-2 virus, published in April 2021, which places good ventilation above the use of surgical masks in the hierarchy of controls. Question, considering this, do you believe that reducing viral load in the room air in healthcare settings should have been prioritised above the use of surgical masks?
Yes. And that's what they are implying there. But as you saw from the guidelines, which were written before the pandemic, it wasn't on the radar in other than a few places. So from the point of people that you're representing, this is hugely important because wherever they're working in the hospital, whether in a clinical capacity, frontline facing patients, or in a more ancillary capacity, they are exposed to potentially aerosols that are produced. And therefore, at least, I'm not saying that the guidelines were wrong in terms of the ventilation rates if they've been applied or applied. What I'm saying is that it should be recognised in the guidelines. However, they were written before the pandemic, and that's why they need to be updated completely. But it's very important that it's not just the clinical spaces, it's the whole of the hospital, if that makes sense.
It does, thank you. Milady, counsel for the inquiry has already answered the second question, so I don't need to ask that one. Thank you.
Thank you very much, Mr. Thomas. Very grateful. Mr. Markery. Are you switched on?
I hope it works.
Sorry, it's my mantra now.
It is, and again. Professor, I ask very few questions on one specific topic. I ask them on behalf of the Frontline Migrant Health Workers Group. To help orientate you, it's page 32 of your report, paragraph 78. And it's the section of your report that deals with the risk of inhaling an infectious dose.
Yep.
So if I can just recap the evidence you gave this morning, really to contextualise my question, but also to save some time, because I have limited time. The risk of becoming infected increases with the amount of particles in the air, i.e. the concentration.
The risk of becoming infected increases with the increased number of particles that you inhale. So if you're in somewhere with a high concentration in the air, so the risk goes up with this more in the air, yes.
Exactly.
Yep.
And the second risk is it goes up also with the volume of air that one inhales.
Yeah, so if you're in a gym and you're working out on a treadmill, you're going to, a huge amount more air is being inhaled. And so therefore, if there's a high concentration, you're going to be taking a load more viruses in. But this does apply in a healthcare setting to people who are actually doing more manual work, pushing loads. I assume someone like a porter would be affected by this. They would be working harder in that situation, so their lung capacity would go up in that. Yeah.
Exactly the point. It's on the physical exertion point that you make reference to in that paragraph. When you exert yourself physically, it has a significant difference in respect to the volume.
Yeah.
Can I give you the example that you use in your report, perhaps to save a little time?
Yeah.
A resting healthy adult inhales 6 to 9 litres of air a minute.
Yeah.
The same adult walking at a moderate pace inhales between 20 and 40 litres.
Yeah, well, I'm someone doing hard exercise, I think it goes up tenfold. Yeah, it greatly increases. So therefore, if you've got particles in the air, you're sampling them at a faster rate.
3 minutes to go, Professor. You say that physical exertion is an infection risk that is often overlooked. Now, do you mean overlooked from an IPC perspective or just generally?
I think both, actually.
Okay, thank you. I'll park that there if I can. So as a risk factor, exertion, you've mentioned porters who are lifting and moving patients, and cleaners who are doing the physical labour of cleaning. That would have an implication in terms of infection, both near field and far field.
Both near field and far field. The only mitigating thing against that is they may not be in that place for that long, especially porters. They may be in to collect the patient and then out, so their duration would be less. However, it may also be for cleaners, but then some people may be in the space for longer. Yeah.
Well, quite. If we take as an example a cleaner, would you agree that a cleaner who's working longer hours, moving between wards, COVID and non-COVID, and the non-clinical spaces that we've referred to in your evidence today, would be at a high risk precisely because their duration is increased and their exertion is increased?
You'd have to do the calculations, but in theory, that could happen, yes. What I do is I do calculations and I do the sums and then see how that works out, how many likely viral particles are going to inhale. But those are all factors. In simple terms, the more you inhale, the higher the concentration, the longer you spend in there, the greater the risk. That's
all things being equal, the longer the shift and the harder the work.
absolutely,
the
if you're in
risk.
there. Yeah.
Thank you very much, Professor.
Thank you very much, Mr. Murphy. Very grateful. Right, I think that completes your evidence, Professor Beggs. It's been a long day for you. I hope it's
Thank you.
not been too tiring, but it's been extremely helpful.
Thank you.
And some very interesting points that you've made. And I'm very grateful for all your care in preparing the report and, of course, in giving your evidence today.
Thank you.
Thank you for your help. Right, 10 o'clock tomorrow.
Yes, thank you, my lady.
All right.